Welcome to PaedsCrib, where we guide young minds to heal young lives through case-based discussions. I am Dr. Manyesane, a pediatrician based in East London. If you find value in our content, don't forget to subscribe, like, and share with peers. And make sure you hit the bell notification so you never miss an update. Let's dive in and grow together. There's two cases that we're going to base our discussion today. Our first case is a 3-year-old boy, previously well, no comorbidities, who was playing next door for the past 6 hours and now is found to have decreased level of consciousness, fasciculations, pinpoint pupils, and excessive secretions. Was also found to have a very wet chest and was found to have a garlic smell coming from the mouth, and he was shocked with a persistent metabolic acidosis and a high lactate. The second case was a 2-year-old girl, previously well baby until the past few hours, who was also presenting with decreased level of consciousness associated with seizures, also had pinpoint pupils, salivation, bradycardia, and also was found to have a noisy wet chest. But this patient was found to be hemodynamically stable, so he was not shocked and he had no funny smells coming from the mouth. Please keep these cases in mind and the differences at which they presented, because that's what we're going to talk about today. Let's look at the background of organophosphates. So organophosphates is actually things that we commonly use, like insecticides, pesticides, herbicides. We actually also use them as chemicals that we clean with in our households. So because they are so easily and readily available, that's why it makes it very common for our kids to have organophosphates poisoning. The other thing that we have to keep in mind, these insecticides, pesticides, and herbicides that we're using, sometimes they don't contain organophosphates, but they contain carbamates. And this is important for us to keep because carbamates can also mimic organophosphates in the way that they present. It is also important for us to keep this as it will help us with our two cases. The age at which poisoning presents in pediatrics is usually less than 6 years, with the toddlers most commonly affected because, as we know, they are very curious, they're eating, they're moving around, they're playing, and children are most likely to present with CNS symptoms than adults, which are most likely to present with muscarinic symptoms or cholinergic symptoms. The onset, the severity, and the duration of toxicity will actually depend on the amount that was ingested, the absorption route, and the toxicokinetics of the insecticide or pesticide that has been ingested. So keep this in mind as it will help us in our next slides. Let's look at the toxicokinetics of these substances. So both organophosphates and carbamates are absorbed through ingestion. They are absorbed through the skin, through the eyes, and through inhalation. And now inhalation has to be found to cause the fastest absorption. This becomes more important when you're dealing with infants or neonates that are presenting with cholinergic crisis, meaning that it's not only kids that are able to eat that can have organophosphate poisoning. It's also kids that are inactive. Let's say if you were using the chemicals, the pesticides, the insecticides, or chemicals at home to clean your home, it means through inhalation, those infants or those young kids can be affected and presents with organophosphate or carbamate poisoning. Now, organophosphates have been found to be lipophilic. What does that mean? It means they have extensive distribution in the body because they are able to hide themselves in the fats. And if they are able to hide themselves, it means they are able to be available for the longest time in the body, and therefore they can cause the longest symptoms. Now, organophosphates have been found to be more lipophilic than the carbamates. That makes sense that organophosphate poisoning patients, their crisis will tend to take longer than carbamate poisoning will do. Okay, and when these substances enter the body, they enter as active already. They don't need the initial metabolism by the cytochrome P450 in the liver for them to start being active. So as they get absorbed, they exert their function already, which is inhibiting the acetylcholinesterase. So when they bind to the acetylcholinesterase, they form a stable bond with it, but that bond is initially reversible. And if there is no dysphosphorylation or decarboylation, which is removal of the organophosphate or carbamates on that acetylcholinesterase enzyme, those enzymes will undergo aging, and therefore the bond that was initially reversible then becomes irreversible, and therefore the patient will present with the cholinergic symptoms and the CNS symptoms that they will have. And the breakdown of the organophosphate, which is the dephosphorylation, is actually longer than the breakdown of the carbamates. That would make sense why also their symptoms take longer, because they don't get broken as more quickly than the carbamates do. I hope this makes sense. So before we talk about the pathophysiology of organophosphates and carbamate poisoning, I thought it was important for us to revise the acetylcholine, because in both these conditions we have an excess of acetylcholine, because the enzyme that is supposed to degrade it is actually inhibited by these substances, which is organophosphates and carbamates. And therefore we have an excess of it, and that's why the patients present the way that they present. So what is acetylcholine? So acetylcholine, if you look at the green thing inside, you have a black dot and a red dot. So the green big thing is your terminal axon, which is in the presynaptic space. So what happens there is that in the terminal axon, that's where your choline together with your acetyl-CoA will unite through an enzyme that acts there and form acetylcholine. Okay, then when that acetylcholine has been formed, it will be put inside into vesicles. As you can see, that round green thing which has red things inside, that is a vesicle. Ne? And for this vesicle then to go at the end of the axon terminal to be excreted into the synaptic cleft or space, there needs to be a calcium influx into that terminal axon. That calcium influx will facilitate the movement of those vesicles into the end of the terminal axon. And as you can see, the vesicle infuses or fuses with the terminal axon, and the acetylcholine gets excreted outside. That outside space is called the synaptic cleft. And then the blue line and the space after the blue line is called the postsynaptic space. And in the blue line, you have the postsynaptic receptors, which are the purple things. The postsynaptic receptors, it's where if your acetylcholine attaches to, those receptors will open to certain ions. As you can see, the other purple one has opened to sodium. So if acetylcholine attaches, let's say this is a neuromuscular junction. So acetylcholine has been released in the synaptic cleft and it attaches itself in the postsynaptic receptors, which are the purple ones. So once acetylcholine attaches there, it will open the sodium-gated channels, and sodium moves into the muscle and cause depolarization and contraction of the muscle. So that's how acetylcholine acts. It acts in places causing contraction or constriction or excessive secretion or all sorts of things. And if you look at the green small thing at the far end of the blue line, that is our acetylcholinesterase enzyme. So there's too many acetylcholines in the synaptic cleft, and that enzyme, it helps in degrading them back into choline and acetate, and then the choline can be recirculated back into the terminal axon for more acetylcholine to be formed. So that's the enzyme we are talking about there. That acetylcholinesterase is very important in controlling the amount of acetylcholine that is found in the synaptic cleft. There mustn't be too much of it, because too much of it will continue stimulating the postsynaptic receptors. If the postsynaptic receptors are continued being stimulated, depolarization will continue happening. Contractions in places that are not supposed to contract anymore will continue. Secretions in places that are not supposed to secrete anymore will continue. Now let's look at the other side. This is where your acetylcholine normally acts. It acts in your cholinergic receptors. Cholinergic receptors or postsynaptic receptors are either muscarinic receptors or nicotinic receptors. Your muscarinic receptors are found in the brain, heart, smooth muscle, and your nicotinic receptors are found in your neuromuscular junction, autonomic nervous system, and in your CNS, in your central nervous system. Now, it's important to know the normal functions at which this acetylcholine will do when it attaches to different organs. For example, cardiovascularly, it actually determines the vasodilation. It can cause vasodilation, it can decrease the heart rate, so it has a negative chronotropic effect, and it can also decrease the contractility of the heart, meaning that it has a negative inotropic effect, and decrease the conduction of impulses from the SA node. So it means too much of it can cause actually arrhythmias also. In the GIT, through the vagal nerve, this acetylcholine will stimulate peristalsis and secretions of the stomach and intestines. In the respiratory system, it can cause bronchoconstriction, and it can stimulate chemoreceptors and aortic and carotid receptors, and then cause apneas and hypercapnia. And in the urinary system, also through parasympathetic sacral stimulation, it can cause contraction of the bladder muscles, and that will lead to the excessive urination that they have. And in the exocrine glands, it can stimulate those exocrine glands also through parasympathetic innervation, like in the tracheobronchial tree, hence the excessive secretion, salivary glands, hence the excessive saliva, digestive glands, hence the excessive secretions in the digestion, exocrine glands, hence the lacrimation and all that. It all can also cause lacrimation in the eyes and affect the pupillary size. So those are the normal functions of the acetylcholine. Now you can imagine why the patients will present the way that they present, because they will have an excess of what we have just mentioned now. After having discussed the role of acetylcholine, it will then make it easier for us to discuss the pathophysiology then of organophosphate poisoning. So what you need is an exposure, as you've just said, and we said that an exposure can be through ingestion, skin contact, ocular contact, or inhalation. And then there needs to be an absorption of the product, and there needs to be an inhibition of the acetylcholinesterase. And we did say that the organophosphate or carbamate, they actually don't need the initial metabolism for them to start inhibiting the acetylcholinesterase. And then once the acetylcholinesterase is inhibited, there will be in accumulation of the acetylcholine in the synaptic cleft that we've just discussed. And that over accumulation will then cause overstimulation of the muscarinic receptors, nicotinic receptors, or both receptors at the same time. So there's lots of mnemonics that have been used to describe the effects of organophosphates in the different receptors. Muscarinic receptors, we use the sludge, S, which is for salivation, L for lacrimation, urination, diarrhea, gastrointestinal distress, and emesis, which is also vomiting. So that's the mnemonic that you can use when you think of stimulation of muscarinic receptors. It will cause the sludge, and we have explained how those symptoms come about when we talked about the acetylcholine. And stimulation of nicotinic receptors can cause something that is called Monday to Friday. Monday being mydriasis, which is the increased pupillary size, weaknesses, weaknesses, T for tachycardia, W for weaknesses, T for hypertension, don't ask me why, F for fasciculations. Then if both muscarinic and nicotinic receptors have been inhibited, then the mnemonic that we're going to use for that is dumbbells. D for diarrhea, U for urination, M for meiosis, which is constriction of the pupil, B for bradycardia or bronchoria, E for emesis, L for lacrimation, and S for salivation. So you use the one that you are familiar with. Most people are familiar with dumbbells, and dumbbells, I think it's important because it incorporates both muscarinic and nicotinic receptor effects that these patients will present with. Now, the other important entity that I would like to discuss with you is the effect of organophosphates or carbamates on shock, because one of our patients was actually in shock. So how did that come about? Please stay with me as I explain to you in details in the following slides. So let's look at how organophosphate poisoning can cause shock. So it's actually organophosphate poisoning that is associated with hemodynamic instability, because we've discussed already, because of the lipophilic effect of the organophosphates, and also the irreversible attachments that they make with the acetylcholinesterase. So they tend to cause more damage than carbamates will do. And shock is actually one of those damages that has been associated with organophosphate poisoning than you would see it in the carbamate poisoning. So the first shock that organophosphate can cause is cardiogenic shock. So as we have said, that the effect of acetylcholine on the cardiovascular system can actually decrease contractility of the heart and drop the heart rate. Both of those things, if they are affected, your cardiac output will be decreased, and therefore your patient will have a low BP, will have a cardiogenic shock as evidenced by the low blood pressure, and they will have decreased perfusion to the tissues, and they will have an anaerobic respiration and have an increase in lactate. The second shock that this patient they can have hypovolemic shock. This is mainly because of the increase in sensible losses that these patients have, because there's lots of secretions everywhere. They're losing fluid everywhere, they're sweating, and also they are not eating, they have decreased level of consciousness. So all those things put together can actually dehydrate these patients up to a level that they will get hypovolemic shock or impaired tissue perfusion because of the dehydration, with also the release of lactate. Distributive shock. So we've said that acetylcholinesterase also at the CNS can actually also cause vasodilation of the vessels. So extensive vasodilation of the vessels will actually redistribute blood into the small vessels, and therefore this blood will not be available to perfuse the tissues. So at the tissue level, you actually have hypoperfusion, anaerobic respiration, and the release of lactate. So this is how organophosphate poisoning can cause shock in pediatric patients. So it's mainly shock is mainly associated with organophosphate poisoning than it is associated with carbamate poisoning. Physical examination, so we're not going to stay much here because we've already talked about most things. So you just look at this for signs and symptoms of muscarinic, nicotinic, and CNS symptoms. So the signs and symptoms are the ones that we've discussed. You use your mnemonics. It's either use dumbbells or Monday to Friday, or you can use your sludge to try and remind yourselves to look for specific signs. But that's basically what you're going to be looking for on physical examination. Now, if you're looking at ways to differentiate between organophosphate poisoning and carbamate poisoning, these are few things you need to look at. An odor, a presence of smell, is usually associated with organophosphate poisoning. It's usually a garlic smell or a petroleum smell. Carbamate poisoning is not usually associated with any smell. Also the lipophilicity. So as we have said that this increases the distribution of organophosphate and therefore its toxicity. The cholinergic symptoms in an organophosphate poisoning will tend to be prolonged because of this as compared to a carbamate poisoning. And also the carbamate bonding into the acetylcholinesterase, it's unstable and therefore short-lived. That will also explain why the symptoms of carbamate poisoning are not as prolonged as organophosphate poisoning. Hemodynamic instability, as we have just said, is associated with organophosphate poisoning. These patients can go into shock with a persistent metabolic acidosis with high lactates. There's also something called intermediate syndrome. This is usually characterized by proximal muscle paralysis, starting from the craniofacial muscles down to the respiratory muscles, leading to a respiratory failure. So this syndrome has also been associated with organophosphate than it would be associated with carbamate poisoning. I hope that helps. And sometimes when you're doing, because the bond of carbamate to acetylcholinesterase is short-lived, you will then sometimes find out that when you're doing the levels, even though the levels of this enzyme in both conditions are low, but those of carbamate poisoning, they'll be slightly low, whereas those of organophosphate poisoning, they tend to be severely low. Now, after knowing all that we know, how do we then make a diagnosis for these patients? So the first thing that you would want to make sure you do is to take your history. So you want the history of exposure. So you want the type of organophosphate or carbamate that was taken. You want the route at which it was taken. Was it ingestion? Was it inhalation? Was it skin contact? Was it ocular? And you want the time of onset of the symptoms. I don't know if I've said this, but apparently the time of onset after the exposure usually takes 6 to 24 hours. Of course, this depends on the type of the toxin ingested. Is it organophosphate? Is it a carbamate? The amount of the toxin ingested, and also the absorption route. So those play a role as to when the symptoms will manifest themselves. 2, you want to know your symptoms. Find your muscarinic symptoms, your nicotinic symptoms, your CNS symptoms, bearing in mind that in pediatrics, CNS symptoms are very common as opposed to your muscarinic and nicotinic symptom. The next step, you want to physically examine this patient. You want to look at the pupil sizes, as these patients can have meiosis. You want to examine the chest, as these patients, they can have wheezes and bronchoria due to increased secretions. You want to assess the muscle tone, muscle bulk, as these patients can have weak muscles with fasciculations. You want to make sure you do your vitals. You look for brady or tachycardias. You look for hypertension. You look for hypoglycemia, as this is an increased metabolic state and these patients run a risk of having hypoglycemias. And then you do your lab investigation. This is where now things are going to be confirmatory, where you are looking for your cholinesterase enzyme. And the one that we do, you have a pseudo and you have a true cholinesterase enzyme. The true cholinesterase enzyme is found in the red blood cells, whereas the pseudo one is found in the plasma. But the one that they usually give us at the lab, because they measure the plasma one, so they will give the pseudo cholinesterase. It's not as sensitive as the true cholinesterase, but it gives you an idea. So the levels are usually below 50% of their normal. And we did say that with organophosphate poisoning, the levels are going to be very significantly lower than the carbamate. Carbamate may be slightly lower or even closer to normal. Then you want to do your ABG. As we've said, these patients can go into shock. They can be dehydrated. They can be hypoxic because of a pneumonia. They can retain CO2 because of a pneumonia. So you want to make sure you assess your blood gas and also check your lactate. You want to assess the electrolytes, as these patients, because of the dehydration and shock, they can have renal impairment. You want to assess the liver. You want to see the involvement of the liver by the toxin, and also because the liver is going to be needed to metabolize these organophosphates or carbamates. So it's important to make sure that the liver is functioning well. FBC, you want to assess if there is any superimposed infection. Then you would want to do imaging. Imaging, depending on how your patient looks like. If your patient is in severe respiratory distress, you want to look for signs of aspiration pneumonia secondary to excessive secretions. You want to look at pulmonary edema that can also occur because of excessive secretions, and you may want to, these patients may have a superimposed bacterial pneumonia that you also want to assess. In a patient with decreased level of consciousness, which persist despite your treatment, despite your atropine and your oximes, and this patient remains with a decreased level of consciousness, then you might want to do a CT brain just to make sure there is no other cause of this decreased level of consciousness. So this is how you would go about in trying to make your diagnosis. And the next thing will be then to try and manage your patient. After having made the diagnosis of this patient, how do we then manage this patient? So the first thing that you want to make sure you do is to stabilize the patient. So you do your ABC. Make sure that the airway is patent. Suction any excessive secretions that the patient might be having. Assess breathing. If the patient is hypoxic because of several reasons like aspiration pneumonia or respiratory failure secondary to muscle weakness, make sure you administer oxygen. And please prepare for intubation, as this patient can need to be intubated because of the severity of the respiratory failure that can be secondary to muscle weakness or bronchoria. Circulation, as we've said, that this patient, they can have cardiogenic, hypovolemic or distributive shock. So make sure you assess for signs of shock, monitor your BP, your heart rate, your signs of shock clinically if they are there. Make sure you give these patients IV fluids and boluses, and you can start the patients on vasopressors, especially if you're suspecting distributive shock. If you're suspecting cardiogenic shock, the patient might actually need to be started on inotropes. Your second step is to decontaminate. Make sure you are wearing PPE during this step. Remove any contaminated clothes from the patient and wash the skin with soap and water. You can do gastric decontamination. This is when the patient has actually ingested the poison and the time of ingestion is within an hour of presentation. Then you can give the patient activated charcoal and gastric lavage. Make sure to avoid inducing vomiting, as this can increase the risk of aspiration in this patient. The third step is to give medication. First line of treatment is atropine. This is a muscarinic antagonist, so it targets your muscarinic symptoms, which are your bronchoria, bradycardia, meiosis. The dose at which we started is 0.05 milligrams per kg IV. We give it as boluses and as double dose every 3 to 5 minutes. So meaning that if you started the patient on 0.5 milligrams dose, you assess the response after that 3 to 5 minutes, and then if you still need to give, you give double the dose that you have given, which is 1 milligram, and you continue doing that. You continue doubling the dose up until you see the improvement. Then once you start seeing the improvement, then you can start the patient on atropine infusion. What's the dose of atropine infusion? So you take the number of boluses that you have given. Check the number of atropine boluses that you have given. You put them together in milligrams, and out of that you take 10 to 20% of that, you give it per hour as an atropine infusion. Then you continue reassessing your patient while on atropine infusion, and make sure the symptoms are improving. If symptoms are improving, you slowly decrease the rate of atropine. If symptoms are not improving or they are recurring, you continue to increase your atropine infusion rate. Now, in patients that then exhibit atropine toxicity, as atropine can cross the blood-brain barrier and cause central toxicity, these patients will start being agitated. Sometimes they can even have hallucinations. So in such patients, you can give glycopyrrolate. Now, glycopyrrolate doesn't substitute atropine. Atropine is still a first line of choice in the treatment of organophosphate or carbamate poisoning. But in patients with exhibiting atropine toxicity, you can give glycopyrrolate. phosphate, as it does not cross the blood-brain barrier like atropine, but it is still also a muscarinic antagonist, so it will still decrease your secretions, your bradycardias, and your meiosis. And make sure your patient is getting atropinized. What do I mean by that? The secretions must be decreasing, heart rate must start going up, the pupils must start dilating, and the skin must start drying up. There is also a role of oximes like pyridoxine, especially in cases of organophosphate poisoning, as pyridoxine reactivates the acetylcholinesterase that can be found in these patients. But this has been found not to have an effect, especially on carbamate poisoning. So that is also how you can differentiate between these two. If a patient doesn't have any improvement on oximes, then you might suspect carbamate poisoning than organophosphate poisoning. Now, in patients that are exhibiting seizures, like in our patients, you can give them benzodiazepines. In our hospital, we give Rivotril. Then you continue doing supportive care and monitoring of these patients, monitoring the vitals, monitoring the hemodynamic stability, monitoring your atropine infusion and atropinization, electrolytes and glucose, monitoring your ventilatory support up until you can safely say you have atropinized the patient, and then you slowly wean them off atropine within the next 24 hours.